Thank you. Bonjour à tous. I'd like to begin by thanking the conference organizers for bringing together an extraordinary group of people from diverse geographies and diverse disciplines. We often travel in our own little tunnels, and so this is quite welcome. So congratulations to them. Let me just introduce the paper by introducing the authors. There are three authors. I'm Susan McDaniel. The A is not an affectation. There are two of us. Two Susan McDaniels. She does psychoanalysis. I do many things, but not psychoanalysis. So I use the A to distinguish that. Germain Bocco is a co-author who sits here. He is a research analyst in the Prentice Institute for Global Population at the University of Lethbridge. And Amber Gazzo is in sociology at York. I'm incidentally a Canada Research Chair in Global Population and Life course. This paper is part of a bigger project, a multi-method project that is funded by the Social Sciences and Humanities Research Council. So we're just going to present one part of it, but there are lots of other parts that are somewhat out and somewhat coming out. I'd like to thank the research data centers at the University of Lethbridge in Calgary for assistance with this. We spend a lot of time there. The last gratitude that I want to express is to the Center for Demography and Ecology at the University of Wisconsin-Madison that merged a data file for us to get geographic specificity, and I'll outline that in a moment, but this is a very important part of our research. Okay, the context. As we know, and we've heard throughout this conference, the association between various levels of socioeconomic status and health are well known. It's also known that there's an association between where one lives, the context in which one lives, geographic specificity, in other words, and health as well. What seems to be not known so much is the dual effect of socioeconomic status and on geographic specificity. It's known that poor health is partially a function of macro level socioeconomic disadvantage. So in this paper, we're specifically looking longitudinally, and I'll elaborate that in a moment, at people in midlife moving into their later years in geographic locations and with socioeconomic advantage or disadvantage. The focus has largely been, although not exclusively, as we know from papers at this conference, on cross-sectional comparative analyses, yet there's widespread acknowledgement, and growing acknowledgement, I would suggest, that socioeconomic conditions and health have a complex time-dependent relationship, and analysis requires longitudinal and repeated measures, which is what we're doing in this paper. So in the paper, we're drawing on research and research and theory from various aspects of this problem. In particular, we're looking at social determinants of health, which I won't outline because that's been very well covered at the conference. We're looking at life course, looking through a life course lens, which is one of the most used theoretical conceptual approaches which on well-being, which suggests to us that well-being in later life cannot be determined by cross-sectional analyses because you're comparing apples and oranges. The older people today are not what the older people tomorrow will be like because of different life experiences and transitions. So what we're looking at is accumulated advantage and disadvantage as transitions are made throughout the life course that may, we don't know for sure, widen in later life. The most evident example of the widening in later life is differential mortality, of course. And that's one of the problems of looking at people in later life. Some of them are dead. And we can't examine who is not in the picture when we do our research. So what we do in this paper to try to capture that is look at people in midlife and then follow them into their later years. So we capture what happens to them. We test income inequality hypotheses at multiple levels of geographic specificity: community, state, province, state in the United States, province in Canada, and country. And we ask whether that's associated with individual well-being statuses, both physical and mental, in midlife and in the older years in the two countries. So specifically, our research questions in this particular paper are two. The first is, do trajectories and overall well-being among adults in midlife vary by levels of income inequality within a community, state, province, or country? And there are 3 levels, of course, there of geographic context. And secondly, does income in midlife mediate this relationship in any way? So in other words, is there an effect of income inequality at various levels of geographic specificity independent of the SES effect of inequality, which is very well known, as we know? We hope to contribute, and we hope, of course, there's always a hope, to contribute to the research literature in several ways in this paper. In effect, we're doing comparative longitudinal analyses of Americans and Canadians in midlife as they age in the context of growing income inequalities in both countries. Income inequality growth is much greater in the United States than it is in Canada, but in both cases, it's been growing quite rapidly recently. And that is known to be associated, the income inequality by itself in macro context is known to be associated with health outcomes at the individual level, even though it's a macro context, no matter what one's socioeconomic status is. So that's a very interesting kind of thing that we're trying to capture. Much is known about the socioeconomic status gradient and its health effects, and we've seen quite a few papers on that, but there's not as much longitudinal work in this as we would like to see, and not much on the magnitude and diversity of disparities as they magnify or not with time from midlife to the older years. Canada and the US share a lot in common, including a very lengthy border. But as most people who live in either country know, there's significant differences. So I just want to mention a few. Healthcare system differences are huge between the 2 countries, and that's visible in some of the papers that have been presented already. There's also a wide difference in the distribution of income levels in the country. There are greater income disparities in the US than in Canada, and more after-tax disparities remain in the US than they do in Canada. Whether that remains going forward or not, we don't know, but right now that's the case. And that's the social policy welfare state effect that people have mentioned already. There's also differences in social disparity, which we know about as well. I won't elaborate. And there are differences in geographical specifics in residential communities. So the US is much more prone, I shouldn't say much, is more prone to have unified socioeconomic status communities than Canada has mixed socioeconomic status communities, sometimes varying from subsidized housing to the very rich within the same community, which is very rare in the United States. So that is the context. Now, I won't elaborate the challenges of comparative longitudinal research because they're huge, and some of them have been mentioned, but there are some that are quite important. Of course, data are very hard to find that are comparable. They don't occur in the same time periods. Ours don't either. So we have to make some compromises. There's other studies by people here have compared various countries longitudinally, but not focused that much on midlife, which is what we're doing, and people as they age, or on levels of geographic specificity. So we're hoping to do this focusing on mental and physical health. Our data, which was decided by the team funded by SSHRC, as I mentioned, which is a larger team than is represented by the 3 authors of this paper, is nationally representative samples in the 2 countries that are generally, and I emphasize generally, comparative. So we use the Canadian National Population Survey, to which a reference was made earlier, from the cycles 1995 to 2000, to the most recent last cycle, 2010-11. I won't go through this because you can see it on the slide, what we talked about, people age 45 in cycle 1. And then we use the US National Survey of Family and Households, and there we have only 2 waves that we could use from 1987 through 1994. And there we have a comparable size sample What we did with this is geographic specificity is included in the NPHS, so that was easy. With the US data, it was more difficult. So this is why I graciously thanked the Wisconsin people for helping us with that. We looked up individual income inequality indicators. We developed them for each of our geographic levels, and then we asked the Wisconsin people to merge those data with the sample that we have from the NSFH, which was very good to have, although we have to keep it very confidential, of course, because it has geographic specificity. So what are our methods? We use multi-level regression modeling, accounting for hierarchical structure of data, two-level logit model with multiple observations. I won't go through all this, but neighborhoods are time varying, entering the model at person level as respondents move in and out of neighborhoods. We can't assume they stay put in a mobile society. And also neighborhood characteristics can change over time. Okay, how do we measure well-being? We use the usual process of, thank you, of self-reported health, which has been shown to be quite good. We dichotomize this into 0 is good, very good, and excellent, and 1 is poor, combining fair and poor. We also use 2 measures of self-reported psychological distress, and these have not been used a lot with respect to the longitudinal data and are quite interesting in the results we find. So these are the two approaches we use, which are relatively comparable in terms of capturing psychological distress. Income inequality, not surprising, which is the main variable of interest in our area level inequality, is the Gini index, which is widely used. Total annual income adjusted for household size, and of course we harmonized it for the 2 countries over time. Let me just see here. For each geographic level, as I mentioned, we computed Ginis. So we have those changing over time. In Canada, the Ginis were calculated for each cycle year, and then we used the distribution of Ginis to classify them into quartiles. We did the same thing once the merged data was used in the States using the US Census and the NSFH. For control variables, you won't be surprised we use the major culprits that we all use. And except for gender, ethnicity, and immigration status, all covariates here are time varying. So some findings here. We looked at, on the left-hand side of the graph, the left-hand graph, I should say, is self-rated poor health. And in Canada, which is the blue bar, respondents in the highest income are about 70% less likely to report poor overall health than are people at lower income. So that's one finding. When we look at the right side of the graph, the pattern is slightly different. There we find higher income have lower depression overall, and the usual gradient of disparities differs somewhat. So in the US, top income were about 60% less likely to experience depression than the lowest quartile respondents, and in Canada it's 45%. The trajectories of self-rated poor health for Canada, which is on the left, and the United States on the right, in the top graphs, and depression, which is in the lower graphs, varied quite a lot. This is just to show how it varied. In the US, of course, we only have two reports, but I think this is indicative of how things bounce around, that they're not totally going in one direction. Here, we began to turn to the findings for our main research question. Does income inequality at a state, province level, or country level affect overall well-being? And Dennis wanted to know the answer to this question right away, and I told him he'd have to wait for the punchline before we got to it. In fact, we didn't include country here for Canada because it will be on the next slide. You'll see some differences because the country differences are not significant, which I think is rather interesting. The summary of multi-level regression models controlling for individual characteristics mentioned earlier, we find that the findings are mixed. In the US, state-level inequality is significantly, thank you, significantly associated with poorer health. In Canada, province-level inequality in the table is not shown, and yet it is associated with higher depression. The association between these are multi-level odds by area level, and in order to try to have it jump out, we didn't include all the numbers, but there you can see quite clearly the effect on self-reported, the effect of province and state level inequality on self-reported health in the US is significant. And in the same provincial level of self-reported depression or symptoms related to distress are significant at the province level in Canada. Here are multi-level odds ratios of self-reported high depressive symptoms in Canada for the US and Canada at the various levels. At the provincial level, no significant differences in the US by geography or income inequality. At the provincial level, Ginies are important in predicting depression in Canada, but more for the third quartile than for the lower quartiles, which is interesting. Here we ask, do trajectories in overall well-being vary by levels of self-reported income inequality? And you note that in the US, there's a trend toward poorer health over time with greater income inequality. And I emphasize here that the nature of our data stopped before what was called the Great Recession in 2008. So in other parts of this bigger project, we're including evidence from that. And our hypothesis coming out of that research, which is being supported, is that these trends in both poor health and poor psychological or mental health have jumped dramatically in the US as a result of the 2008 depression and home foreclosures and job losses and all of that, which created a great deal of turmoil. In Canada, our findings from another paper are mixed on this, because Canada survived the Great Recession considerably better than the US. So it should be noted before we turn to conclusions that there are two major potential limitations here, other than the ones that I mentioned of data comparability and timing. The first is that we only have 2 data points for the US, which is unfortunate, but that's what we could find for this. And the second is we were not able to control for all covariates because of comparability and data limitations, so only a limited number are used. Discussion and conclusions. Here we examined relationships between income inequality and health longitudinally among Americans and Canadians in midlife as they move into later life with harmonized data, harmonized income data, and harmonized data as much as we could achieve in other realms. The evidence for area income inequality hypothesis is mixed. There's no evidence that older people are more susceptible to harmful effects of area income inequality in Canada, neighborhood or community or provincial effects. The state-level income inequality is associated with self-reported fair or poor health in the US. Household income is most strongly associated with each of the health incomes in both countries. Thank you very much. Merci beaucoup.